My name is Dr. Khulood. I'm from the UAE. My background is family physician, consultant family physician. I'm graduated from Dublin and Harvard University. I work currently as the head of clinical standards and guidelines. This means I actually write standards and guidelines for the health facilities. I also analyze and look into different platforms that has AI in particular. Recently, I've been certified as an AI ethical assessor, and this would be incorporated to the new standards of digital health. I also work as an advisor for different embassies, currently with the New Zealand Enterprise and Business Sweden. So happy to be here.
Mohamed Farghaly, I'm a consultant family medicine and diabetologist. I'm professor of medicine at Dubai Medical College, and I'm advisor and consultant in the health insurance system in Dubai.
Thank you very much for introducing yourselves. So let's get straight into it. So value-based healthcare has different definitions depending on wherever you look. So I'm really interested from your perspective, what is value-based healthcare to me? In your own words, define what is value-based healthcare and what the purpose of it is in Dubai particularly. So Professor Mohamed, if I can ask you first.
The best definition which I like scientifically and practicing is the best outcome that matters to the patient while reducing the cost and patient centricity. We would like to have our patient in the center of what we are doing. So in the meantime, if we are talking about the expenditure in health, which is increasing day on day, we can tell that the only way to have the full service for our community is to go through value-based healthcare. The existing model of payment will not work if we would like to have a universal health coverage, which is the role now. Why we start now the value-based healthcare? Because again, we would like to provide the best services of to our patient. With the existing model of pay for service, we can't do that. We would like to do payment for outcome, and we would like to have the payment which is justified for our patient, plus applied the value-based healthcare.
Thank you. Very, very thorough definition. And Dr. Khulood, if I can ask you, so you mentioned, Professor, about universal health coverage. That's, I think, one of the drivers, certainly, for the momentum. What other main drivers are there, really, for the momentum that's being gained in value-based healthcare, particularly in the region? So perhaps if I can start with you, Dr. Khulood.
I think if I spend the whole hour speaking about value-based healthcare, it's not going to do any justice. I just want to add a little bit to what Dr. Farghaly has mentioned. So when it comes to value-based healthcare, I think the most important factor is what it means for the patient. Did we actually make sense to the patient? Did he reach his value? So for example, doing a surgery on a patient and the doctor's job is done, it's paid, everything. Is this the outcome the patient needed? Or have we improved his quality? Or how does he feel afterwards? It's reaching that value is what matters the most. So for another example would be something like equity. Having equity means having equal access to healthcare. We all know that. But do we have equal outcomes for healthcare? This is the question. So I think this is where value-based healthcare lies, in my opinion. And just to answer the question, there are a lot of factors that are involved when it comes to value-based healthcare. First of all, I want to ensure that there is transparency in the whole process. The patient has to be aware of what's going on all throughout the process and the outcome. If there is an AI component, he should be aware that there's an AI component. Transparency is not only within the patient, but even with physicians to each other, private and public sectors, insurance and providers, healthcare professionals. They all have to be involved in this. The other aspect would be like a patient-centric approach, so ensuring that the patient is always involved. It's not the center and everything around him. It's not like that anymore. The patient has to be an arm in the whole process, so he can be involved in the whole process of his outcome. And at the same time, everything that he needs has to make sense for the patient. If the patient doesn't understand it, if the patient doesn't need it, there is no point of having it. So technology might complicate things, or it might ease things at the end of the day. And finally, I think regulation is very important because we set up the rules, we set up the standards, we have to ensure that there is value-based healthcare. We have to ensure that what I've already said earlier is implemented and is measured accurately.
Thank you very much.
Just to add some of the more drivers why we have the value-based healthcare. Now we know that the life expectancy of our population here is around 78.3, which is matching the European and the American. Chronic disease is much higher. If you compare us to the Western population, according to cardiovascular outcome trial in the GCC, our population here are getting diabetes, hypertension, and all chronic disease 10 years younger than the Western population. Again, you would like to have the universal health coverage for everybody. Expenditure in health, if I can tell you that from the data of Dubai, we spend around 31% of the expenditure in health due to drugs. So we have high innovative drugs coming to the market here, but again, it is in very high cost. You would like to look to all this when you would like to change the model of payment to pay for outcome rather than pay for the service. So moving from volume to value.
The outcome side, the payment side, the policy and regulation, the clinical standards side. So we'll try and touch on all of those points. But I want to start with the outcome piece and the patient-centric piece, because I think you touched on it, Dr. Khulood. It's one of the most important aspects, keeping the patient at the center and monitoring the patient's outcome. How do you choose which outcome measures to monitor?
First of all, we have to ensure that the patient is an arm in the whole development, so it's not just in the center. I think that's very important that he's involved in the decisions, because what we're measuring is the outcomes that matters to the patient. And basically on what we choose to measure is we have to measure what matters to that patient in that specific scenario. So if we're looking, for example, for diabetes, are we just measuring the HbA1c as a number, or are we measuring the final outcome or the values that comes with it? How does the patient feel when he goes home? Are there any other complications, the psychological aspect? There are many areas that we need to look into. Once we have those measurements, it's very important to compare our best practices with others and learn from each other, because if there is always learning, it's a vicious circle of learning from each other, then there is always a chance of improvement. And if there is a chance of improvement, this means there's a chance of being innovative. And if there is innovation, we're increasing patients' value. I don't know if that actually makes sense, because it all goes around in a circle.
Professor Mohamed, if I can ask you to add to that, and then perhaps make specific reference to the IJADA project, because I think what we've seen is that's probably one of the most well-established and certainly most progressive projects in value-based healthcare globally. So if I can ask you to comment on that, please.
Yeah, I think IJADA is the real model of implementing value-based healthcare in the area, because you are looking to different aspects when you are going to assess the outcome of care. So you are looking for the clinical outcome, link this to the economical outcome, patient safety, operational, and add to this the patient-reported outcomes, PROMs and PRIMs, how the disease affected the life of our patient. And this is very important or integral part when you are talking about IJADA, because it will tell you exactly how is the performance of all stakeholders in Dubai, including the healthcare providers, the payers, the patient, and the all the speciality, even per physician. You can tell from IJADA how is the performance of each physician in Dubai through our dashboard, which collect the data and make automated analysis of this data. So you can tell from the performance through the e-claim system in Dubai, you can tell how is the performance of the hospitals, different specialty, physicians, and the payers. So based on that, on IJADA, you would like to go through the major diagnostic categories. Means when we think about IJADA, we think about the high expenditure in health and how we improve the outcomes that matters to the patient through assessing the high volume, high frequency, and the number of patients, the number of episodes, and the prevalence of different disease. Based on that, we can set priority which disease area we would like to start with. We have the situational analysis of the gaps between the available guidelines and the real practice. So filling these gaps, you can see how is the performance on the market. You develop the standard of care, you develop the KPI, you circulate the KPI to the market, train the providers and payers on the best practice, and then you assess the outcome of care after applying IJADA. So you are going to assess both before and after Ijada, how the system is improved both in quality plus economical. So if I get the best outcome, which is better than the performance before Ijada, and in the meantime you reduce the cost, so you reach the equation of value-based healthcare. And this is really what happened in practice in Dubai.
Thank you. And I want to come back to ask you a little bit about the challenges and barriers of implementing that. But before I do, I want to ask Dr. Khulood about the clinical standards that align with that, because I think a lot of what we see where attempts to embed value-based healthcare exist is that the standards and the regulations around do not align with the aims of the projects that are being implemented in value-based healthcare. So in your role as head of clinical standards, what steps have you taken to try and align how the standards are written and how they're directed based on value-based healthcare and outcome-based care?
So we do have a process in which our standards are developed. We always involve different stakeholders in the development of the standards. So we involve, for example, specialists in the care. We align them with insurance and other internal departments. We also ensure that there are experts in the field that are part of it and our patients as well. So everybody's voices is reflected on the standards to ensure that it's quite comprehensive. We have to make sure that the standards address the patient holistically. So when we look into the patients, if we want to look into KPIs of measuring surgeries, we're going to get surgeries. But we want to look into more than this. I think it's not enough just to comply to guidelines, because we can all do that. I mean, complying to guidelines doesn't make you a good doctor, but measuring patients' value does. And that's a different way into looking into things. And it's very important to think in that perspective. So if a surgeon does a procedure and the patient goes home, that's not the end of it. He has to ensure that the patient is having a good quality of life, that the patient's not having any complication. It's not the end of it. The KPI goes on measuring other areas that are mattering for the patients. And this has to be reflected in the standards.
Thank you. And just back to the Ijada implementation, what barriers have you seen in attempting to embed it? Because I'm sure there were probably some barriers, some challenges. What have you seen, and what experience can you share for other sort of regions or organizations trying to implement such a project?
First, let us think about the demography of Dubai. We have 200 nationalities in Dubai. We have different backgrounds of practicing physician in Dubai. You would like to, not to unify, just to put the guidelines. And the guideline is a frame. It is not a protocol which everybody have to follow. No, it is a guideline. Within the guidelines, they are going to manage disease areas based on the best available evidence. And we benchmark with the OECD, 38 countries in Europe. And we benchmark Dubai to this group. Again, the availability of data. Since 2014, we have the big data. We are talking about 4 million insured population. All their claims, they pass through the post office of Dubai. So we have the data of 4 million population. Again, if you talk about the quality of data, when we started Ijada and looking to the quality of data, the usable number of data was not that much. You can generalize to the population from these numbers of quality data. We raised this, and it was a big challenge for us to have a unified number per patient in order there is no duplication and there is no bias in the data. Now I can assure everybody that we have 92% of the uploaded data are usable and clean data. Based on these numbers, you can generalize. This is the main challenges which we have. Again, the resistance. Everybody sometimes when you come with a new challenge, people always resistant to change because you are changing completely the model of payment from pay for service, as much as you do service you will get paid, to pay for outcome. And if you are talking about pay for outcome, everybody sometimes, especially the providers, will be resistant. But applying the preparation of the guidelines, well-established guideline, either we adopt or adapt guidelines. We have a group of physicians always all over Emirates who are working with us from the Emirates Medical Association to develop guidelines or adopt guidelines, developing KPIs and conducted training. Till today, we conducted 29 training sessions for both providers and payers on the best practice. So we are allowing everybody to go through our guidelines. And these guidelines, very transparency, it is uploaded in our ISAD website. So if there is any debate between providers and payers, they have to come back to the guidelines. Now, I can tell you that in the performance in Dubai, they will not say that we are going this evidence based on FDA approval. They are going to the evidence based on IJADA guidelines, which is a great success for Dubai Health Authority.
Thank you. And you talked a little bit about the diverse nature of sort of both the Dubai population and the clinical workforce. So perhaps if I focus a little bit on the patient-reported outcome measures, a lot of patient-reported outcome measures are perhaps validated in sort of Western communities, and the things that matter to some of those communities and some of those patients may be different from the things that matter here. So perhaps, Dr. Khulood, if I can ask you what work has been done or what steps has been taken or what experiences you can share around localizing and contextualizing, particularly the patient-reported outcomes and experiences to match the local population and the local population needs.
Okay, I mean, what you're talking about is algorithm bias. So we have to ensure that we are reflecting all our outcomes based on our population. Sometimes we can benchmark and we can look at best practices abroad. It might not be very applicable to what we're providing in the UAE, and I think this is the most important thing. It has to be applicable so that it can make sense to the patient, and it has to make sense to us as well. So we do our measurements based on current practices in the UAE. When we do our situation analysis, we actually see what are the demographics, what are the gaps, what is needed, and then base our KPIs on them. Another area that I want to talk about is the importance of leadership in this case. And when it comes to value-based healthcare, there are different types of leadership that we need to look into. So the strategic leadership is we strategize how this would work at a higher level. And then we need a transformational leadership in which they'll make that change at a lower level with the people. And I think one leadership skill that people tend to forget about is the systemic leadership. And this is the leadership where we learn from each other. So we see best practices abroad, best practices in the UAE, and compare results and see how we can get equally better results rather than, yes, DHA is doing better than everybody else, ha ha ha. It's not like that. It's you're doing great. How can I learn from you? How can I get better?
And one thing that I'm really interested, so I'm an orthopedic surgeon by background. I appreciate both your backgrounds sort of in family medicine and diabetes in particular, but there is a distinct difference, I believe, in how you measure outcomes for and how you monitor outcomes for chronic disease than perhaps more immediately surgically curable disease. And one of the most interesting things for me about IJADA is a lot of the conditions that you focused on are chronic diseases, which is very different to a lot of value-based attempts elsewhere, where the primary focus has been sort of surgically curable, you know, orthopedic surgery, hip, knee replacements, cataracts, etc. So why have you chosen to focus on those diseases? We've touched a little bit on the population, but what are the differences or challenges in measuring outcomes for the longer-term chronic diseases as opposed to the sort of immediately curable surgical conditions?
I think when you know the concept of PROMs and PREMs is new to our area here, and to add it for the assessment and performance of our stakeholders in Dubai or in Emirates in general. We started with studying the model of EQ5D, which is applicable in Europe. And we had a study of 1,000 population here regarding applying the EQ5D to this group of population. We have data which is published already. When you are looking to the 5 diameters related to the chronic disease, it will work more with chronic disease versus the acute disease in order to get the patient input or patient voice. And we consider this is a part of our assessment of the performance of each healthcare providers in Dubai. Not only the clinical, economical, but again, patient voice, it will make a difference. And we are building a new system which is coming soon related to the PROMs and how it will be applicable and how it will be shown on the treating physician room, and he will get a pop-up about the patient idea or how the disease affect the life of this patient and how the medication or the management plan done for this patient, what is the patient reflection on that, other than the part related the happiness in consultation and how the patient experts regarding or experience regarding the consultation is happy with the doctors, how he receive him, how the consultation goes, and all these matters. But what again it makes difference is how the disease affect the life of our patient, which we would like to introduce to our system thoroughly.
I disagree with you, Michael.
Okay, tell me, please.
So even acute procedures like orthopedic, they do carry risks and it has to have a comprehensive approach. So something like a hysterectomy, for example, it's becoming a straightforward procedure for women, and it's basically removing the uterus. The surgeon is done with his procedure, but the hormonal changes that affects the women, the psychological trauma that might occur. There are multiple factors when it comes to comprehensive care. So it's not just at the end of doing a simple procedure, which for a surgeon, yeah, it's the end. I've done it. I've cured. The job is done. That's why I'm not into insurance. I am the insurance expert here, but I do believe in a bundle approach when it comes to measuring outcome, when it comes to insurance, because the physician shouldn't be paid by the end of the procedure. It actually should be paid by the end of the outcome of the patient. And I've seen this practice happening in some parts of the world, and I strongly believe in this because the end of the job is not at the end of the procedure. It has to be at measuring at the end of the patient, and that therefore increasing his value, therefore patient's happiness at the end. I mean, he has to go through the whole journey.
Yeah, and I completely agree with you. And I think the challenge that we see is exactly that. Where do you define the end? So, for example, in a lot of where we see sort of orthopedic proms implemented, the end is often maybe 6 months, 1 year, 2 years post-procedure. And I actually agree that there should be a drive for a lot of the surgical specialties to move to a longer-term sort of follow-up, as we do with chronic diseases, because you have to, in order to make sure that you follow the journey all the way through with the patient and start to pick up any deterioration, because deterioration may happen 1, 2, 3 years down the line, and part of that patient journey is to identify that and then rectify. So I completely agree with that.
Absolutely. So if a surgeon does a knee surgery, he'll ensure that there is a good physiotherapist that would take care of that patient and follows up the journey. If he wants to be paid, he will ensure that a good physiotherapist would take care of that patient.
Absolutely. So you touched about bundle payments. I think it's a good segue to talk into insurance and different payment models and a move away from the traditional sort of fee-for-service model to more innovative models. So perhaps I can ask you, Professor Mohamed, about different models that you think work best in terms of, remunerating providers and making sure that these things stick. We've seen models, for example, in the UK that incentivize sort of community-based outcomes with a top-up payment, things like sort of best practice tariffs. In other countries, they use sort of more bundle payments. So what do you use here, and what are the differences and pros and cons of different models?
We were going for pay-for-service for long times. And as I mentioned, because of the challenges and the high expenditure, we changed the model of payment. Especially we started with the inpatient, the bundle payment for inpatient. Then we got some of the practice when you are going to get paid for arthroscopy, for example, and it was an inpatient procedures. We pay for it around 28,000 dirham, and then if you do it daycare, they get paid 31,000 dirham. So people in practice here in Dubai, they change arthroscopy from inpatient to daycare. Now we are coming with daycare. Daycare is already in practice. We have the daycare now to control the payment to be justified payment. The next step in end of 2024, 2025, we are coming for packages for outpatients. So when you reach it to all these models, which inpatient, daycare, and outpatients, you are going to control the market. Actually, we have some data which we are going to publish soon related to cost reduction when we're applying the bundle payment. And if you go to Ijada, where we are going to make the score for the all healthcare providers in Dubai, you can tell per disease area and pay pillars. So we have 4 pillars to assess. Add to this is the patient-reported outcome, where you can tell that if the patient is if the providers is doing well for the outcome of care and reduce the cost, he will be in the top priority and he will get incentivized. Those who are below the Dubai standards, they are not, they will get training, and again, they will get period for improvement, reassessment. So we are talking about a very important topic related to the management of health in Dubai as a regulator.
And yeah, it's a very good summary. And thank you very much, Dr. Tamara, for joining us.
Sorry, I was judging in hall 7, so it's a little bit of a long go back.
No, thank you very much for coming. And we're just talking about sort of enabling value-based healthcare, and we've had a bit of a focus on some of the work that's been done in Dubai, particularly with the Ajada project. So perfect timing for me to ask you to, if you may, just introduce yourself to the audience and then tell us a little bit about the work that's been done in Saudi around value-based healthcare.
Sure. My name is Tamara Sunbul. I oversee health informatics at Johns Hopkins Aramco Healthcare. I also play the role of I chair HIMSS Middle East community, and I'm part of the global digital health platform, and it's like the WHO for digital health, and there I chair the evidence and evaluation work stream. So it's a pleasure to be with you all here. And so as you probably heard a lot about Saudi Arabia and Vision 2030, and us and Johns Hopkins, we've been working towards implementing the value-based care. Easier said than done. I'm sure you've heard from these two great speakers about the challenges. We've just recently implemented NAFIS, which is our health information exchange. There's a clinical side and there's a financial side, and that is crux to development and population health. Because remember, population health is nothing that most of it doesn't happen in the hospital. For value-based care, most of the care happens at home, at work, where people are. It doesn't happen in clinics. So our challenges basically in the clinics in our areas is how do we capture all that information? Because these patients might not even ever come to the hospital. So how do I reach out? And that's what we're looking at, those care gaps and what we need to do to get there. And for me, if you ask me what is your biggest challenge, I would say clinical documentation improvement and capturing that information, not only about the patients that are coming in, because guess what, I'm a clinician, so I can tell you when I write my history and physical and I put my one diagnosis in the system, I only put one because I'm always in a hurry. I want to get that patient out of the room and get the next one in. So I don't bother to capture all those comorbidities. So I think that's one of the biggest challenges is getting the clinicians to capture everything and going beyond those clinicians and capturing what's happening at home, whether it's through patient questionnaires, whether it's through wearables, and that outreach piece. So it's a two-prong approach is how do I identify the patients and what they need? And then in my system, how do I gather all that information, drive insights, drive outreaches?
Thank you. And you've touched on some very important points I want to dig into, actually. One is around data capture, and particularly sort of pathway-specific data capture. And the other is around the clinician side. And so you're all sort of clinicians by background. You've all gone into senior policy roles, and you have an interest in value-based healthcare. So you're not the ones we need to convince. The clinician that you talk about who's in the room with the patient, who's in and out, very quick, one after the other, who is resistant to some of these. And some of the resistance conversations we've heard are perhaps around, well, value-based healthcare doesn't always capture very complex patients effectively, or that actually, why is my sort of reimbursement dependent on patient compliance? And they're sort of the clinical sort of resistance arguments that we hear. So perhaps if I can ask each of you, starting with Dr. Khulood, how do you win over those clinicians? How do you win over the skeptical clinicians and get them to buy into the vision of value-based healthcare as you've described it?
I think my colleague, Dr. Tamara, touched on something very important when it comes to data. So having a health informatics system that is connected is one way of solving this problem. So in Dubai, we do have Nobel, in which all the health facilities are connected through a health informatics system, so that physicians that are able to capture on their dashboard everything that the patient went through previously. So a patient might come to me, I'm a physician as well, and a patient comes to me and might not tell me every comorbidity he has, but he might have said something down the line to another physician. And if this is captured on my platform, I will be able at least to tackle that issue, and I'm aware that the patient's it's in there. It's all stored in there. So this is one way, I think, and training the physicians to use this and training them how to think through this dashboard and how to utilize this technology would also one way of tackling this problem.
And perhaps, Mohamed, if I can ask you sort of the same question, just about any other sort of thoughts or ideas in challenging that resistance from the end user clinician.
Actually, if we are talking about the practice, if you are talking about value-based healthcare, and whatever physician is going to apply is applying value-based healthcare or best practice to his patients. When we are developing guidelines or standard of care, it is not a protocol everybody should follow strictly. No, they have to go through it. Sometimes, if you look to the level of evidence, A, B, C, D, and E, E is the expert opinion. I can do my experience in certain disease areas, but I have to defend if things goes wrong. What I'm talking about, for example, I give real example of applying the value-based for upper respiratory tract infection and unjustified use of antibiotic. How much we spend in this? We spend a lot. Why we spend a lot? Because the prescriber, according to our data, 86% of physicians, they prescribe antibiotic in the index date. Means the day I'm seeing the patient, I'm going to prescribe antibiotic. What is the rule according to NICE guideline? If you go with NICE guideline, you have three options. Either you give the antibiotic on the same day, no antibiotic, or delayed antibiotic. Again, if I agree that everybody should prescribe antibiotic, their style of prescribing continue to be the same. So I'm prescribing 8 out of 10 antibiotic. Now what I'm prescribing? Second generation or third generation antibiotic? The right example according to WTO latest guideline to treat upper respiratory tract or otitis media or sinusitis is to start with first line antibiotic, which is amoxicillin. Amoxicillin cost the course is 15 dirham. If I'm going for second generation antibiotic, I'm paying 120 dirham per course. So we have data related published for us in ESPOR in 2019 related to 4.9 million episodes of upper respiratory tract infection. 4 million are prescribed antibiotic. Multiply 4 million times 120 and multiply 4 million times 15. How much you are going to cost? The end result is the same. So you are going to get, because again, it is self-limited. Whether you give or not to give it is 4 to 7 days and your patient will be fine. But the difference is you prescribe 15 versus 120 times 4 million. You calculate it and tell me how much we can reduce if we apply the evidence-based practice.
I think that's a really important point, and I think one of the most powerful things that I've seen in convincing, in moving away from that resistance of end-user clinicians is that data. So I think that's I think you both touched on that. I think that's a really, really important point. Dr. Tamara, if I can ask you to add to that, of any other sort of experiences you can share.
Definitely. I like what Dr. Khulood said. So there are a lot of technological tools that you mentioned, including CDI, because we don't want to make it very cumbersome for the clinician to look for those diagnoses. So there are tools that you can leverage, digital tools that will actually pull up those diagnoses based on what's in the record through language processing and be able to pick it up. And so what Dr. Khulood is saying is easily there, just one click and you can pull it in and you don't have to worry about more work for the clinician to do. And Dr. Farghaly, it brought up very important subject, which is pathways and evidence-based order sets, and that is inbuilt into the record. So automatically, with of course links to the evidence, so that when the physician says, no, this is not best practice according to who, he can actually click the link and see the evidence. So if you do have those digital tools, that really helps drive a lot of the clinician adoption, because there won't be any ambiguity around it. And to Dr. Khulood's point, it will be able to capture seamlessly. But I see the major crux is actually changing our payment models. It's up to health systems, regulator, to change how we reimburse our physicians. So one thing that we are doing, that we are assigning panels to all our primary care physicians to promote this. So everybody gets his own panel, and for that panel, which is actually risk stratified. So we do risk stratification and we make sure that they're equal. for those patients, what we do is we say, you as a physician are responsible for this panel. And based on this panel of patients, you have to we make it very easy with outreach tools. They need to call them to come in to do they're due for their mammograms, their cholesterol screening, or all the wellness screening that is out there. Make it really easy for them. You can do bulk outreach. For us, you can select all that are due for something and just send, and you can just do one bulk outreach. So make those physicians accountable, and based on that, also that's how you reward them. So you make sure that you say, this is your panel of patients, and I'm going to give you a compensation. I'm going to give you 25%, because you know that whatever you're paying is going to come back to you. Maybe it won't come back to you ROI this year, but 5 years from now, 10 years from now, 30 years from now, that's where you're going to see less diabetics, more controlled hemoglobin A1C, less people on dialysis. So it's changing the way we deliver care. And I think you're a lot of her seeing especially in Saudi Arabia, Vision 2030, and a lot of what we're doing around the Gulf states around value-based care. We're changing the way we compensate. We're no longer pay per service. We're moving into DRG. We're moving into outcomes. So you will see risk-based capitation come in place. You're going to see a lot of these new payment models. But to get there, we need to mature. We're still not ready there from the way we capture the data, or the way which we have those guidelines embedded. It's not till all that is kind of ready till you will see a lot of this stuff come into interplay.
And so are you suggesting to some degree that we push more on the financial incentive first and the change management will follow after that, rather than the other way, which is what some other countries have tried to do?
And that way they'll embrace. So all the digital technologies you hear from Dr. Khulood and Dr. Farghaly, those won't, like, if you put them now, they're going to disregard them, right? They're not going to click on those things, and they're not going to ask their hospitals to implement them. But if you say, I'm going to get you compensation, they're going to come back and say, well, you need to help me. I need tools for CDI. I need embedded clinical decision support. I need something to help me do that outreach. So it's not till we do that, till they come back and they're going to shout and they're going to push their hospital systems to, you need to help us to get to where we need to go.
Thank you. I want to leave a few minutes towards the end for questions from the audience, but I want to touch on one last thing, which is the role of the rest of the supply chain and the role of industry in this, because we've touched a lot on the payers, the providers, we've touched on the clinicians, the patient side, and I think the rest of the healthcare sort of supply chain, ourselves included, Open Medical, and perhaps some of the other members of the ABHI, are interested in the role that we have to play in value-based healthcare and how we can be part of that change and transformation. So perhaps, Dr. Khulood, if I could ask you first to comment on that and give me your thoughts.
I mean, a third of the data that is available, third, is all medical health. This is how important it is. And if you look into the airlines, for example, they tend to talk to each other somehow that you get a ticket in A and reach B in no time, very seamless. It's not the case when it comes to healthcare. So I think what I want to emphasize on is we all need to talk to each other for this to become more seamless. As I mentioned earlier, regulators need to be talking to people and to policymakers and to patients. Physicians, private sector and public sector has to have that joint connection. They have to have that partnership. We have to learn from each other. Patients needs to be involved. The community needs to be involved. So it all has to be there, transparent and seamless to develop that foundation of trust.
Thank you. And Professor Mohamed, if I can ask you just to comment again on the role of industry and how we can support that. Obviously, data being one aspect, as you say, but and sort of interoperability and the communication between the systems. But just to add any further thoughts to that.
I think everybody in the stakeholders for the health system in Dubai, I'm talking about Dubai, they have to come together in order to get the best outcome for our patients. The main issue is the patient and the VIP of the health services, the patient. All of us here because of the patients. This is help us when we are practicing, teaching, and regulator in the meantime. You look to the pharma, for example, when they do affordability program for their patient, they go to pay for the high cost medication, and they are going to make affordability or charity programs for the patients. We ask them to come and make this agreement with us. We have more access to patients, and we have the simple discount which they give it to the charity, they give it to the patient themselves. And instead of paying administrative fees to third party to manage this, no, they give it more for the patient. Again, we would like the insurance pay justified payment. If you compare between you go out of pocket versus you go with the insurance card, the ancillaries or the test done when you pay out of pocket is 1/4 of what you pay if you are going with insurance card. Again, everything should be controlled. And we would like our physician to have the evidence-based practice. We know that as a regulator, we would like to have cost effectiveness management plan, not cost reduction, cost effectiveness, in order to reallocate the resources to different disease area.
So I think generally, just to answer your question, I think one actually just remarking on what you said, Dr. Farghaly, I think we forgot the patient's role in this, right? So we're saying provider, everything to the provider, but we also mustn't forget the patient, because we also need to provide the right incentive for the patient, whether it's rewards, discounts on their insurance premiums, rewarding good behavior. I've seen some of like Ta'awuniya in Saudi Arabia and some of the companies already doing that. So to answer your question, I think we need to create an ecosystem. It's not one hand. It's we have to have an ecosystem of partners. We need patients who are part of the care. They're the center. They're at the center of it. We need the payers to be aligned with us. We need the providers. We talked about the clinicians and all to be, as well as the regulators and legislators. So these all need to come together, and not to forget, most importantly, our vendors, because our vendors need to be aligned with our vision and where we're going. We need to all get together and work together to create this value care. It's not one of these institute by itself too will not. Everybody has to come together. I will say, one hand can't clap, two hands can clap, but many hands can clap very loudly together. So, thank you.
I think that's a very nice note to finish on. So perhaps if I can just open the floor just for any questions from anyone in the audience.
Thank you for your time. I'm Talia from NAPTA Health. We're a women's health clinic based in the UAE, and very alike to what you think. We're trying to promote preventative care, which is, in our eyes, synonymous with value-based care. And I think the challenges that we face is trying to build those connections with insurers and to kind of speak the same language. And perhaps one of the three of you can kind of help us a little bit. What is the messaging we should be kind of discussing with insurers to make sure that we're on the same page, and that essentially there is as much as skin in the game for an insurer as there is for us in promoting preventive care for our end customer?
I'm not taking that. So I think it's creating shared value. I think it's sitting with those insurers and decide and agreeing on where you see the shared value. And basically, once you create that shared value and you're both agreeing upon it, it's a no-brainer. But just to sit and show the data and show where you want to go and creating that shared value, I think that's the initial step you need to overtake. I'm not sure if my...
We believe in dialogue. And when we are talking about the health insurance system in Dubai, we have partnership with providers and payers. And we have the health insurance forum, which we meet together and we discuss problems. Don't forget that people who reject and approve in the insurance are physicians. But when they are reject and approve, it should be based on evidence. Before, sometimes they have the American system, they say the FDA say so and so, I'm going with FDA. And the British, they go with NHS, and they say NHS say so, so we'll reject. Now we have one language for the insurance in Dubai. We are using the ICD-10, we are using the CPT code, we are using the American standard for dental, and we have all this system all together. They talk the same language in coding. So when you code on the right way, and you are going to pay for the justified payment, this is the language. When we're conducting IJADA, we get everybody together. We get the payers, we get the providers, we explain the guidelines, and all of them are agree. Very transparency. We put the guidelines on our website, So if there is any debate or argument between providers and payers, they go back to the guideline. So now we have a single language, everybody talking in order to reach the goals or the objectives of the healthcare, which is patient comes number one.
I'm just going to add that that partnership is together with us as regulators, as clinical standards, together with the insurance. So we revise those pathways and ensure that it's aligned with our standard with a scope towards prevention. So the KPIs are measured and aligned together. So they're basically based on value measures and patients' rights, patients' protection, safety, and prevention.
Thank you, panel. Really enjoyed the session. My organization's work with providers across the US, the UK, and out here in the Middle East. And everybody's striving towards the same thing in value-based care. My question to you guys is, how do we ensure we don't add a huge amount of manual work and activity and push downstream what maybe was focused on clinical coding or other activities down to those to now measure these KPIs and quality metrics to officiate who gets paid for the according to the outcome in whilst we chase VBHC?
Definitely. I think this is where technology comes in, right? Because it's not, I mean, we should not be sitting and doing, asking our clinicians to put in codes and translate and then having our denials and insurance and all that. We should make it very easy. So there is a lot of technology out there. And right now, anybody who's trying to do value-based care, who's sitting in pen and paper land, no way, it's not going to happen, right? So there's no way this can be done manually. So you need to make it as automated as possible. There is a lot of, right now, natural language processing, CDI tools, digital CDI tools. So anybody trying to do value-based care without CDI tools, without digital registries, without EMRs or systems that are capable for outreach, patient engagement tools, it's not going to happen, right? It's going to be a lot of overhead. You're not going to be able to accomplish. You're not going to be able to get, like Dr. Khulood, the ticket. Your plane is not going to go where it's supposed to be headed. Okay, you're going to take a lot of detours, and you're probably not going to reach there. So it's that initial investment, and again, it goes back to legislations, governments, and actually assisting hospitals and health systems that are going to implement it. In the future, I know maybe you're working in the US, so I see a lot of accountable care organizations taking up. So we're not seeing them now, but in Saudi Arabia, at least, I don't know how it is in the UAE, but our vision are ACOs. So we are, and right now with what we're doing with our hospital, Johns Hopkins, we are trying to spin up an ACO. So that ACO structure where we prioritize prevention before intervention. And so when these things start up and people kind of understand where we're going and they start to implement these systems, it should be very easy. Otherwise, we can't engage the patient, if we can't get the clinician to do things very seamlessly, and we don't capture data seamlessly, then it's, everything, all the data and all the interactions need to be a byproduct of the clinical documentation, which should be seamless.
I think in Dubai, I'll tell you a real model, not theories. When we started Ijada, we have built on in Ijada, we call it Ijada Plus, which is MDS 360. Where there is 950 clinical and economical indicator built in the system. Now we are interpreting 105 indicators classified into clinical, economical, patient safety, and operationals. Based on that, you can calculate the score of each providers in Dubai. We have real data, and we have data which is already will be out by the end of this quarter 1 in 2024, shows the performance of everybody in Dubai, the providers, the payer, and the clinician. In the clinician, I'm practicing, they can see how I'm doing, how many patients I saw, how many patients I go with guidelines, and how many patients are deviated, I'm deviated from the guideline. My score, whether I'm applying value-based or no, where is me from the score of Dubai and the standard of Dubai. We have the traffic light, which shows green, you are doing good performance with low cost, yellow, good performance, high cost, red, which is low performance, low cost. So this all is in Dubai now, and it is not theory, it is real practice.
I think my colleagues gave a very comprehensive answer, both of them. I just want to add probably the AI ethics when it comes to implementing technologies. So we will have to ensure that it is all ethically assessed in terms of accountability, accuracy of the information. So we want to ensure that there is no algorithm biases when it comes to reflecting to the population, and the outcome will serve the patient's interest.
I just want to also add one thing just about the cost. I don't want anybody to go out of here thinking that we're trying to save money or cut cost. We just believe that when we say value-based care, it's the right care. Actually, sometimes when you spend more and you do extra care, it results in an adverse outcome. So we're saying we are delivering the right care that the patient needs, not more care that can result in an outcome. So I don't want anybody to misunderstand that we're trying to cut cost or anything like that.
Hi everyone. Thank you so much for your time today. It's absolutely refreshing to see everyone talking about value-based healthcare. My organization, we're actually a value-based healthcare specialists, and we have a platform which connects all the stakeholders together, and mainly it's pitching in with the patient side, facing in and actually having that say of how their treatment is progressing, and more importantly, being rewarded for sharing that data back in. One of the questions I have for you guys, and no one's mentioned that at all, is the trust between sharing data between the ecosystem within the payers, the providers, and so on and so forth. How do you ensure trust in the work that you guys do in your organizations, and trust in the data, and making sure that everyone's getting a fair share? And more importantly, how do you ensure risk sharing for those outcomes-based agreements, for example?
I think for the trust on the data upload, we have the system which you can validate the data submitted to you, because we have double system in-house service, and the provider service or the vendor who get the data through our post office. So if you get any data, first we would like to make sure that the data is clean by having one unified patient numbers. So member register is number one. Number two, we would like to, in our system is customized system. Means if today I'm going to assess the hemoglobin A1C for one patient, so there is a range before when we start, 2013, when we start our system, and we start to ask the providers to send us their data related to hemoglobin A1C, we got the figures 00000. I got 84,000 claim, 54,000 of them are zeros. What we did at that time as corrective action, that we send the range of each results, what should be done, and everything should be passed through within the range. So if I'm talking about hemoglobin A1C below 4 or above 20, it will not come to 000 plus. If you would like to get paid for the system as a process of care and outcome of care. As a process of care, you have, if your patient is well controlled in diabetes, you do 2 times per year. If is not controlled, 4 times per year. You can't get paid except if you upload to us the results, and the result, it will show whether it is above 7 or below 7. Based on that, we are going to pay you. So you make sure of the validity of data submitted by the providers. Now we are introducing new things this year, inshallah, which is the medical necessity. Medical necessity means that at the level of the treating physicians, if there is a mismatch between the CPT code, ICD, and the prescribed drugs, you will get pop-up of rejection. And as you know, all the system in Dubai, our government is paperless, all are automated, but with control. This control now we are using, the first gatekeeper is the payers, but from second quarter, we will have the medical necessity as first control to make sure of the data which we have is a valid data. Again, we are applying the punch samples. Punch sample is a way of assessing the performance. I go for example, they use this in factories. When you are going to give a product and they go to the factory and they get punch sample and assess it. How is it going with your product, fine or no? So this is again, we are going to assess this in the level of providers. How to get pharmaceuticals to trust that data?
I think the question is, how do pharmaceuticals trust that data? Is that what you're asking? Yeah.
how to get the pharmaceutical to trust the data. I didn't get you. Tell me again.
So how do you get the pharmaceuticals to trust that data? Because the only way that, in my experience, after implementing hundreds of agreements, is to have stakeholders all having that risk involvement in there. So pharma will only trust the data if it's sitting in a neutral in an area. Yeah, exactly. Pocket. How will
We
they
have
trust me?
a certain agreement of management entry agreement, and we have the pay for performance program for the high cost medication. We have an agreement of some of the pharma companies related to high cost medication for lung cancer, for example. We have 8 cycles of treatment they pay for. If the patient is responding, in the Center of Excellence, they assure that the patient is responding, we continue payment. If not, we are going to get money back. This is one way of improving or showing the actual performance of medication from the pharma side. Pharma, they would like to be, if you look to the pharma in general and to the cost of medication in general in our area here, we are the highest, second to US. Why? Because Emirates would like to be number 1 in getting the innovative medication to our region immediately. We don't wait for the medium price. Medium price, 17 countries outside US, this time after we get the medication here. But again, our medication here in our area is very high even compared to Saudi. Saudi, even they got treatment or drugs cheaper than us. They believe in what we say because we have data, we can analyze everything related to the medication. Everything related to medication with steering. So we used to say that we are classifying our medication into 3 categories: the low medication, the middle, and the high cost. High cost medication is a negotiation between us and the pharma to come with a new formulary for our health service in Dubai.
For your question about trust, I totally agree, and the way we've done it in Saudi is a little bit different. So I know the things, and when I hear more about how UAE does things, it makes me like, I guess you have different like payers and the different insurance companies. So we have a neutral system. So we have a neutral database that we upload our data in. So we have something called Nafis that I talked to you about. So it's a neutral. It's a live stream of my system, my information going into the system. So that's where, if anything, if anybody wants to question, that's where the claims get questions. That's where everything gets questioned. Combination of clinical data and non-clinical data, independent, because we all know that anybody can adjust the data that gets sent. So I totally agree with you. You need to have a neutral platform. For us, it's easy because it's one system. Here in the Emirates, I guess because each one has its own system, it becomes a little bit comfortable, a little bit complicated, and you need more legislations. But for us, it's easy because it's one system. So we don't have to deal with the headaches you guys probably have to deal with.
It's actually one system here where the insurance will be part of the informative system, so it's only one system. But to answer your question, it's very important to have transparency in the whole process. So from the input to the output, if I'm able to figure out as a regulator how did A turned out to be B, and I'm able to explain it to you, this means I understand it. And this has to be the case with every stakeholder involved in that process for you to trust the system. And it has to give out the same answer all the time to ensure that there is accuracy. So in the UAE, we do have a system in which is very transparent. All of the stakeholders in the health regulation are aware of that system. All the stakeholders involved in the products, that include pharmacists that are involved, pharmaceuticals, legislations, insurance, have access to that system, and we all agree on the same pathway.
Thank you very much, everyone. I'm conscious of time. Thank you very much for giving up your very valuable time to join us. We really appreciate that. I really appreciate the discussion we've had. I think we've touched on some really, really essential points from keeping the patient at the center of everything we do. I think data and data transparency and data capture in a granular fashion throughout the entire patient journey made available to everyone so that there is that transparency and trust in the data, I think is essential. And obviously the role of digital in that really cannot be overstated. I think digital is the future in implementing all of these, and the work that's been done with the respective health information exchanges, I think very much feeds to that. And certainly I think the financing is the other key bit, and are really interesting in the model where we push the financial model first and the rest follows, which is very different to where attempts to implement value-based healthcare elsewhere globally have been. And we probably didn't touch as much as perhaps we would have liked on the prevention side, but I think that's another sort of key aspect, but I think maybe that's for another session. But thank you again very much for your time, really appreciate it. Hopefully if you do have 5 minutes to hang around in case people want to say hello, but thank you again very much, do appreciate your time.
And thank you to all the audience that came to listen to us.